and diagnosis of cancer also integrated home care services. And about economics, it was more in particular the income. The AMPI method is a method that normalized and aggregated these singular factors and attribute a score to the geographical area, so we could have a map with different levels of rating divided into quartiles. And in the second part of the study, we compared also the maps of the rating index with the maps of the single variable we mentioned before. So this is the preliminary results of our study. This is the rating index. You can see 4 shades of red. The more intense one is the higher value of the rating index, and we can see that it on the mountain areas of the province, and it has a higher value. Moreover, for the city of Modena, for the northern area, we have medium high value of rating. Comparing the index with the single factors, we saw that the socio-economic factors, in particular low income and elderly subjects with age about 8 and over years old, are the most important regarding the parts of the south of the province. Comparing the health status of the population, you see that the worst characteristics about health are about the city of Modena and also the northern area, and that you can see looking at the maps of the prevalence of chronic diseases and the cancer incidence. Our findings are about we found differences in fertility levels in the province, with the mountain areas showing us the greater needs, and influenced by higher age in particular and the lower income. Instead, for the northern area, characterized by worse health status, we need to further investigation to identify specific determinants of it. This rating index helped us to summarize the health status of the province, considering different factors of different area and different aspects. And the use of this index would be appropriate to develop in describing different aspects of rating. And about the future project we have, we want to do an analysis of the sub-municipal areas, in particular in the city of Modena, and also about the trends, because to combine the use of these analytical indicators with different analytical indicators to support prevention and public health activities. Thank you very much.
Thank you so much for your presentation. What do you think you're going to do with mostly for use a similar index for identifying people particularly vulnerable to heat waves tourism or what are the main?
Yes, good morning and thank you for the question. Bologna, in fact, was our inspiration to this study. And so in particular, the next one will be about the distribution of chronic disease of different types of chronic disease.
Okay.
You said that you found differences between the areas.
Mm-hmm.
Differences statistically, or was it just because of the distribution when you saw the
Like that, you see. Okay. It was the methodological statistic analysis that called AMPI gives us a representation, but now we don't still know what um, are the implication of this. So we saw there is higher rating in some areas and lower rating in other areas, but we are starting to see what the concern is. Thank you.
Okay. If there is no other question, we will move to the next speaker. Thank you very much, Valentina. Next, we have Ricardo Mazzoni.
Okay, thank you. Hi, thank you. I'm grateful to be here. So my presentation is about a study we're conducting The announcement is one by around sugar, a lot of plant-based, foods, very processed foods, not many plant-based food. That's it. Thank you for your attention. The announcement is one by around.
Yeah, that's what's working. Thanks so much for your presentation. I just have one question, which is when you are presenting the objectives and methodology, you were very influential and trying to those independent analysis. And in the end, when it comes to results, you will reflect on the difference of between healthy and healthy plant-based diet. Why did that analysis came up in your work? Was it about the research at all, the research fundamentation? Did it come as an ad hoc analysis? How did this come up?
It was just from the videos. You can see in the exposure, we had everything, like just the difference to a plant-based diet. These includes the PDI, which is the plant-based diet index, which is the index we are using to, not every study has it, but you can see it properly. They are cool when you're presenting, but then the plant-based, so 5 studies, the PDI. Then you have 4 studies with, you can see the first study at the plant-based. So we could, in those 4 studies, we don't have healthy versus unhealthy. But in the PDI, you have a score. So from a 0 to 4, I guess, it's unhealthy. Then we have normal PDI, and then we have from 8 to 12, I think. It also depends, it's not a general, but you have healthy. And sometimes studies divided into quintiles. So then we try to match up the quintiles with the general score, so that we could have homogeneity between all the studies that use PDI.
Okay, thank you.
Thank you.
Okay. Is there any other question? We can take a very quick one. No? Good.
Thank you very much.
Yes, is Julia.
Good morning. I'm Julia. I'm public health medical resident in Portugal in my first year, and I'll be presenting this literature review on the use of digital resources in travel medicine. This came up because it's important to provide information to travelers in order for them to adapt health practices during their travels. And this is a digital age, so it's important to explore which the interaction and resources and how digital medicine can help cater to diverse traveler needs. So this review was conducted on document with this expression and included articles from 2000 to 2023. These articles, of which 20 were deemed relevant, excluding languages of English, and articles whose was outside of the research. From this search, the main things that we found was articles discussing mobile application use of travel medicine, updated collection via smartphones, disease risk analysis, and digital communication evolution throughout these decades. Discussing travel-related health gaps. One such article identified 23 health gaps in the territories of travel medicine and malaria, 2 of which were developed by the CDC, Some others provided travel alerts, and in malaria, the main purpose was providing information on symptoms, treatment options, and recommendations. Um, Even though there's not much evidence that using these apps can help travelers recall the advice provided during pre-travel consultations. It was useful for patients, it reduced the duration of the consultation, and eased the workload for the doctors. Um, there was also a discussion of what these health apps could help do and what they could be used for, especially tailoring these outbreak alerts, providing advice on where and how to access medical care in the foreign country. For instance, providing information on supplies for immunoglobulin when necessary, retrieving health records, providing information on air pollution and ultraviolet light indexes, also warnings for natural disasters, and also to help evacuation procedures when necessary, and providing drug alerts when conflict. They could also help reduce jet lag, reinforce adherence with chemoprophylaxis by issuing reminders, and recording all the exposures to facilitate post-visit diagnosis, post-travel diagnosis. There was also some articles that related to health data collection via smartphones. This allows for collection of the environment, the itinerary, and the weather, and could also help identify hotspots health problems and update travel advice for specific regions and routes. And some of these data, it was possible to identify the non-infectious disease-related issues that were the most common, but they're not as much addressed in traditional travel medicine research. So these data could improve health evidence-based advice. It was also useful for monitoring health status on a daily basis, also providing specific medical advice and providing remote contact, avoiding the need to health service. And it was found that people use these apps more when they're traveling for longer periods of time, and to solve math problems that could be dealt remotely. But there was also some concerns over the rejection, user fatigue, and data overload. Other articles reflected on the evolution in digital communication and analyzed how the acceptance of electronic consults in travel medicine. The majority, they compared two groups, and the majority of the electronic consult group preferred it, and the face-to-face group, at least a third, felt that it would have been done remotely. So electronic consultation is just as effective as face-to-face, and can be useful as an alternative. Also, at first, travelers were using newsletters from public health departments and online resources, and they were interested in information that dealt with health promotion, vaccines, health hazards specific to the areas they were traveling to. But it was found that there was a need for this information to be standardized and accurate, and especially on commercial travel reservation websites. So, from these articles, we can see that these could be effective tools to disseminate information to travelers, such in all stages of travel medicine, in pre-traveling, during the journey, and also providing personalized health guidance and post-travel. It could also be adapted to different realities of travelers. but there's also the need to reflect on that some regions don't have internet access, and this accessibility must be ensured. So to conclude, these studies highlight how relevant these interventions are, the potential of the technologies in travel medicine, and the need to adapt strategies so that they can be useful for all demographics.
Thank you very much. Next, we have Caterina Santos. Okay, go ahead, you can start.
Okay, thank you so much. Thank you everyone who got up early this morning to be here and supporting our presentation. I am Caterina, I'm a medical resident here in Madrid, in Hospital Universitario de Madrid, and I'm originally from Portugal. And today I'll give you a little presentation about an automation process we developed at my hospital in order to analyze the microbiology about the results, in order to optimize the epidemiological surveillance we have to do at the hospital level. And this may sound a bit weird, especially for colleagues from countries where we only have public health as a specialty, but here in Spain, we have preventive medicine side of the specialty that is starts at the hospital level. This is not a preventive medicine service with our nurses, doctors, medical residents, and our secretary. And we have a task at the hospital that is epidemiological surveillance. This means that we have to control and follow hospital-acquired infections, other multi-resistant infections that may be of value, other microorganisms that require transmission-based precautions, and mandatory notifiable diseases according to the guidance we have from our local public health office here in Madrid. So we decided we needed to develop an automated, easily replicable system for detecting notifiable diseases, hospital-acquired infections, other relevant infections, based on the results from the microbiology service at the hospital in order to optimize mostly the establishment of transmission-based precautions at the hospital level and or public health interventions when needed. And this may sound a little bit weird as well, so we are going to have a little fast. Spain has a little problem or a little peculiarity that it has a federal-like organization and health competencies are distributed to each autonomous community. So each community has its own health system, its own informatic system, and they do not communicate with each other. And then even when we go at the level, like the community of Madrid, well, we have different electronic health record systems between different hospitals and between primary care and hospital care. And even at a hospital level, most of the times microbiology systems don't really integrate with the electronic health record systems, and it's very, very hard to get access to information. Most public health residents from Spain will tell you we spend a lot of time just going through data and trying to gather the information we need in order to act and to protect our patients at the hospital level. There is no homogeneity in the process. Each hospital does it its own way, and if you look at each hospital individually, probably you'll find even residents that live differently between each other, and it's process that is very person dependent, and this is a risk for patient safety. So
we decided that if the system was not working, we needed to talk between each other, and this is not an easy thing to get done, especially here in Spain. And we needed to develop systems that allowed us to have access to this information. So we talked with the microbiology system at our hospital, with the ITs from our hospital, the data center we have, and we developed an SQL constellation that would allow us to access the large information system and download all the transferred microbiology data from our hospital, but also from primary care and outreach clinics, because the data centers are also aligned with our hospital, and in some cases we need to be from hospital level. So before this, we were actually going physically to the microbiology lab and reviewing every result by hand in sheets of paper. And when we developed this system, we started reviewing them at our computers at the Preventive Medicine Service. We were reviewing 500 to 1200 results per download, and we were doing 3 downloads a day. And we were visually checking every result, just scrolling down with our mouse at our screen. It's very time consuming, and as you can imagine, very, very overwhelming. So we decided we need to take a further step, and we developed a very simple script in R that will allow us to filter the results and at the same time creating and updating every time we do a download our data matrix. It also generates automatically a safety copy. And we decided that with the new data that we collected, we would apply broad filters in order to have smaller lists with notifiable diseases, hospital-acquired infections, or multi-resistant infections, respiratory tract infections, and clostridium infections. These are the ones that concern us the most regarding the hospital following or the notification of diseases. It's very important that we establish broad filters because we don't want to miss anything. Besides that, we also reviewed the new data. We generated a file with every new data every day, every download we make, and we reviewed that as well just to make sure we are not missing anything. So the results from October 2023 to February 2024, we had 102 working days, and doing 3 downloads per day, we had a total of 692 new records every day. If you recall, we were having 600 to 1200 results 3 times a day that we had to review. So now we are having much less number of cases that we need to review. This corresponded to 28,000 unique health record ID numbers. These are numbers that identify either patients or environmental samples. So you can see through the number the type of analysis you make, if it's a patient or an environmental sample, but it was a total of 28,000 unique health record numbers. And this conveyed 925 notifiable diseases. We also had over 1,200 potential hospital-acquired infections or multi-resistant infections. We found 795 respiratory tract infections that do not include either COVID or flu because we have separate systems to detect these two cases, and 200 Clostridium infections. All of these were new samples that were positive. Some of them may correspond to patients that already had these infections and were just new samples that mean they still had infections or were colonized with these bacteria. So the main results and the most important conclusions we have is not only that the automation of epidemiological surveillance at the hospital level needs collaboration of several units. We need to put in common the language we're using, how we are calling things so we can filter them and have access to the results, enables a more efficient detection of relevant cases, and contributes to a reduction in the likelihood of human error that at hospital level is very important. It also generated a raised satisfaction among professionals involved in the process because we do not have to spend that much time doing the visualization of everything.
Hi, thank you so much for your presentation. I have only one question. It seems to be that mostly you described a procedure that you try to implement in your working place, but then when you come to the conclusions, you write down and you present the conclusions that this process was more efficient, and that it reduced the likelihood of human error. Did you do any comparative analysis to come to these conclusions, or you simply get the perception from implementing this procedure that this should be what happened in comparison to what you did before?
We only got the perception. We didn't do a comparison study, mainly because it's something we've implemented on our everyday basis work, and we didn't have the time to do the comparative study, the comparative results in everyday life of clinical medicine at the hospital level. We have 1,200 beds, hospital beds at my hospital, a little more, and all the outpatients, so it was not possible to conduct a study comparing the two results.
Thank you.
Yeah, thank you. Amazing work. I have the same question, but did you see maybe any trends compared to previous year, the same period, if you were able to detect more diseases this way? This is one question. And the second question is, I think we have a very similar problem in Italy, especially with a different IT system, very hard to integrate. But did you find did you manage to get everyone on board? How was more like the process of getting everyone on board and make this work?
So, regarding the first question, we still haven't done a comparison because we started in October with this process. Firstly, we reviewed all the new cases every day just to ensure missing anything and just to adjust the filters. And now, once we have a bit of a larger way, we are going to do a comparison because we do have the records of what we were detecting last year, for example. So we will compare the results. And regarding the getting everyone on board, what we found was that my hospital is a relatively old hospital here in Madrid, and there are a lot of relationships that have been chronically established a way or another. And what we found is that we as medical residents do have the power to be more than we think. And the fact that at my service we get along with the other medical residents, and we have one of our doctors really likes this kind of work and has worked closely in other projects with the IT team and with the data center. This helps. When people know you, when you go, you present yourself, you explain what you're trying to do, you explain that you're doing it that not only for you to have the data and to publish or anything like that, but for the patient, for everyone to get along and to gain from it. People usually, especially if you start with younger generations, they come on board. And then you just have to go up the chain and just slowly convincing the people that are above you. And mostly, the most important thing for us was that we show them we are doing this faster, we are taking less time on our daily life, and it is allowing us to do other things at our service. And to the microbiology team, especially, it was like this is something that will help you as well. It's just standardized how you report multi-resistant, for example, multi-resistant microorganisms. And this will help you to have a structured information as well. If we all have access to the data and it's easier, then we all can do a lot more for our patients.
Thank you very much. Thank you. And we will go.
These are the topics I'm going to have here in my presentation. First of all, sexual transmitted infections are mandatory and notifiable in almost all countries of the European Union, but we know that underreporting exists and is a significant issue because it prevents us from adjusting our intervention strategies, our intervention strategies. So the aim of this work was to quantify the underreporting of STIs in Baixo and Tejo region, which is where I'm doing my residency. And for context, we have a population that represents only 1% of Portugal population in total, but we have an area that represents 9.3% of all territory, making it the biggest, largest region of the Portuguese territory. Methods that we used, so we searched data from 2018 to 2023, and of these specific STIs, HIV, syphilis, non-congenital syphilis, chlamydia, and gonorrhea, and we used two platforms. The ESC clinical platform, which is where the clinicians codify the diagnosis of their patients, and they use the APC, the ICPC2 code method, which we have here for each of these STIs that we are studying. And we use the CRs, which is another platform, to extract data from that S clinical. On the other hand, we have the platform of SynapMed, which is where our colleagues, clinicians, they notify us of this mandatory notifiable disease. So we use our part of the SYNAP, the public health part of the SYNAP, to extract the data of the SynapMed, and we compared both data of these two platforms. We excluded from this analysis some STIs, for example, urethritis, because there's no way of knowing by the ICP-6 method if it's chlamydia caused or gonorrhea caused. Viral hepatitis does not have a specific code for each of the hepatitis. The ICP-2 code only has the code of generally viral hepatitis. And it's not always, they are not always STIs. We excluded herpes, herpes infection, HPV, and trichomoniasis, because these are not mandatory notifiable. And we also exclude monkeypox, mycoplasma, myoplasma, hemophilus influenza, because they are not mandatory notifiable and they do not have specific codes. So these are our results in of all reported cases of 981 of S clinical. Again, where they codify the diagnosis, we only had in synapse notifications 134, meaning that they were only reported around 14% of all codified diagnoses. Meaning that there was an underreport of 86% of total cases between 2018 and 2023. Again, 86% of underreported, which is very significant. And here we have the graph that shows the real difference between each of the STIs. The most relevant one would be HIV, where we have 514 qualifications, but only 55 notifications to the public health system. You can see here the percentages are very similar, around 10 to 15% of each, except chlamydia, which is the best one, with almost 30% and 6% of cases notified. There are limitations in the study. First of all, because we exclude such a lot of STIs, we do not have the true characterization of the real and the reporting of STIs. Codification to codify, make better codifications for us to be easier to analyze the data. And Portuguese law, although it provides the obligation of notification under penalty sanctions, rarely it was applied as sanctions or fines in, I don't know, many cases, really. So this can lead and leads to a disregard of notification by physicians. Again, if nothing really happens, why bother, right? But basically the biggest conclusion is that it's up to us, because we are the ones that our intervention is compromised if we have underreporting of numbers. So it's really up to us public health, to demonstrate the importance of this data to our colleagues, to the clinicians, because really it influences our decision making and our strategies and our interventions. Thank you.
Hi, thank you for your presentation. I was quite surprised that such a high rate of underreporting of data. So, what are your hypotheses to explain these results? Thank you.
I was also surprised. Basically, the first work that I wanted to do was to see if there was an increase in STIs in my region until I got the data and I realized that we had another problem, a bigger problem, which is underreporting. I was quite surprised negatively about these results. Again, I think that's one of the reasons is that there are no actually penalties, even though they are mandatory not to follow. There are penalties if they do not report. Other issue by talking to our colleagues is that they say they lack the time to notify because this is a process and takes time. And they have a lot of things going on, and they really do not have the time for that. And some of them they do not know which are not obligatory notifiers. So that's why we are using this to intervene in that area, to sit with them, to talk with them, to ask them why is this happening, not in a police way, but really to understand their point of view for us to make some kind of to help each other to reduce this problem.
No?
Thank you for the presentation. My question was, why did you choose to assess the quantification on the side of the primary care physicians, not, for example, of hospital doctors, as you said in the limitations? Because I think that we can imagine that maybe hospital professionals would be more following the protocol, and maybe if we look at the data at the hospital, do you think that maybe we would identify like higher reporting, or do you have any comments on that?
I do not know because I don't have data. I can only assume that no, because especially the ones that notify most in the hospital, most notifications come from the emergency wards, and they have less time to notify because they are always so busy. But we only use the primary care data because the CRs that we use only has the data for the primary care system. So we only use the CRs. We didn't use the hospital database.
But is there, I'm just wondering, if there is like another database in Portugal that you can identify in the hospital, like the codification? I think like for HIV, for example, it would be, it's not directly a question to you, but I think that it would be interesting to see like how often they report like HIV cases, because often it's diagnosed like in hospitals, and how often it's actually copied like as the diagnosis code, as a proposal.
That's very interesting. Thank you. Because who puts in the system to diagnose, it's usually the primary care physicians. That's why notifications to SNAP of HIV can be in hospital, but the code, again, the code of diagnosis is done by their primary care or primary care physicians. That's the main reason. And again, because it's anonymized, the notification that comes now can be from the hospital. We do not know where it comes from exactly.
Very quick picture. This picture is a simple graphic, and all the cases that are identified are new cases. New cases, new diagnosis, or the prevalence.
No, these are only. We only have the data of the absolute number of is the data from 2018, 2023. So, no, they do not repeat. Is that the question?
Yes.
No, they do not repeat.
Thanks very much. Okay, and now we have Esther Garcia.
Good morning, everyone. I'm Esther Garcia Exposito, and I'm going to talk about this study called Transuser Experience in a High Complexity Hospital here in Madrid. So there are already some researches that shows that LGBT people faces health inequities just because of their sexual orientation or their gender identity. One of them is, for example, one comparison caring. The results of this study says that 73% of trans people and 29% of gay, lesbian, or bisexual people reported discrimination in any of these ways: refusal of needed care, abusive language, for example, or even being physically assaulted. So, in one of the parts of the health system is the hospital, and a colleague and me decided to explore this in my hospital. The main objective was to explore the experience of trans users in a high complexity hospital, and as secondary objective, we wanted to identify areas for improvement in their healthcare. And how did we do that? We proposed a descriptive qualitative research, mainly because we don't know a lot about this. So we wanted to have an open mind point of view to investigate this, and we thought this was the best way. We did 3 semi-structured interviews to trans users undergoing hormonal transition process in the hospital, and then we also did a focus group with 7 health professionals that belong to services that were directly involved in their care. So it was a compulsive sample selection. We called the endocrinology service and we said, we have this study, can you please send us the list of users? We collaborated, and then with the professional we sent an email, and they also have a really good answer. And this took place in October 2022. So let's start with the negative results that were quite a lot. First of all, they highlighted the difficulty of accessing the health system, and also the lack of information on the part of health professionals. And this was said both by health professionals and also by trans users. For example, a lot of them said that when they went to the primary care, they had to explain the doctor how to do the derivation because they didn't know how to do it. And this was really hard for them. This was the first time they go to the health system, they find a barrier, and it was really difficult. And also professionals, they agree with this, and they say they have no training for treating them, and also they have no protocols or guides about which are the resources the hospital has or primary care has to derivate them, for example. Here you have the verbatims about the discourse they told us in the interviews or in the focus group. They also talk us about long waiting lists, and this is something quite common right now in Spain, but for them it was especially difficult because of the moment they are living. They are in a moment where they have a lot of problems with bureaucracy for changing their name, with telling who they are to their family, to their friends, and they said it was really hard to wait, for example, 6 months or 9 months to the first consultation. And also with there were problems with, for example, cryopreservation. There was a really long wait waiting list, and uh, until they cannot access that, in some cases they cannot start the hormone treatment. So it was a problem. Related with this, health professional proposed the creation of an interdisciplinary structure because they said this will facilitate really much the process to the patients. There would be the specialties involved, endocrinology, gynecology, urology, psychology, and they saw this like a really good improvement. And then also they asked for initial communication with the endocrinologist, mainly in the first phases of the hormone treatment, because after for hormones, they need like to regulate levels, and it was easier uh, communicating with him or her. And also they found it difficulties with, for example, shortages. Last year they talked about shortages, and it was only the specialists who could prescribe the hormone treatment. So if they went to the primary care, it was impossible to change it. And also there were other things that were in the discourse, such as, for example, migrant people. They say if they had just come to Spain and they had started the process in their countries, they have a lot of problems with hormone treatment because they have not access to the public health. So in a lot of cases, they had to go to the private system, and this was really expensive, and they didn't have the controls they should have. And also the lack of follow-up in consultation traditionally assigned to cis women or cis men. For example, they talked about in the emergency, if a trans man goes and it's a person who has uterus or ovaries, it's not contemplated that he can go to the gynecology, or even it isn't thought about by the professionals. But there were also good results. They said they had a really good treatment on empathy of most of health professionals, mainly from specialties that treated them usually in the transition process, and also that their preferred name and pronoun were respected in these services mainly, but also, for example, in emergency, although they said that it was person dependent. Like there are no rules, there are no protocols, it depended on the person that they were with. And the good experiences in general in these services. So, as conclusion, we saw there was a lot of negative results in their experience, so there are great opportunities for improvement. Mainly more training for health workers, update protocols to guide trans users, and also the creation of this interdisciplinary structure. And finally, also we thought that qualitative approach is a useful tool for this kind of researches. That's all. Thank you very much.
Hello, thank you so much for your presentation. I have two questions, if there is the time for it. One of them is a compound question. So even though the data in your work is qualitative, did you do any comparative analysis, first of all, among LGBTQ people and other people without this characteristic, and among LGBTQ people, if you only analyze that, did you try to make any comparison, for example, between departments, between kind of professionals interacted with, or any other thing, or it was only a descriptive work with all LGBTQ people?
Okay. Thank you for the question. It was just a descriptive job. I mean, we didn't do any comparison because in the first approach, we wanted to see what was happening. So we didn't see it was like the moment to do that. I think we will have to do that, but first we need to know what's happening. And also about comparison between professionals or between services, it was not possible. I mean, the objective in this type of studies is to have the the separation of the discourse, and it was not possible because it was really difficult to get to three interviews, and also really difficult to do the focus group, so it wasn't possible.
Thank you so much. I just have a follow-up question, which depends on your perception. So, do you think that the way questions were placed to the participants was good enough to make it clear the difference that these people were experiencing because of their LGBTQ condition characteristics? Or do you think that the final results might also depend on the overall limitations of the healthcare system in Spain? For example, the fact that you wait a long time, etc. Do you think there was a good way of posing the question so it would differentiate, or it might be influenced by the overall experience?
Yeah. I think we did a lot of questions, so we could see both of them. I mean, we asked them about discrimination just only because in the perception, of course, but being LGBT people, and also about the limits of the system. But I think we could analyze it. We could see it. Yeah.
So I had two questions. One of the question was the same as Francisco. So my second question was that, so you said you did three semi-structured interviews. So how difficult was it to maybe recruit more to do more interviews, because maybe there are like different perceptions.
Yeah.
And also, do you know how many patients are followed in the center where you did these interviews? So my point is these three interviews representative of the patients?
Yeah, no, they are not representative. I mean, also there were different ages, and that is really really important because it has changed in the last years a lot, like the process and the options they have. It's not, but I mean, I think it's also part of the qualitative research. We have to like explore what's happening with the data we have. I mean, I think in the next step we will have to explore differences between age, between services, between everything. But first we need to let them to tell us what's happening. And it was really difficult to do the study and to get to three interviews. Also because I mean, it's really new. All of this is really new, and it was hard to get to do the research. Yeah, in the hospital.
Okay, because it was difficult to reach these patients, or
it was difficult to reach the patient and also to contact the specialists to have the contact of the patients.
Okay,
Yeah.
I understand.
Yeah.
I will have to catch it. Answer the question. I think should already be available during the conference.
Yeah, of course.
Okay. Sorry. Okay. Thank you very much. We are moving to Rafael Bastos.
My name is Rafael Vasconcelos. I'm a publisher, health medical resident in Portugal in the fourth year. And this work is called carpool karaoke phenomenon or promoter of distracted driving and seat competencies. A proof of concept study. So, as most of you know, road injuries are a quite big issue regarding disability adjusted life years and years of life lost, because they are mostly responsible for deaths in the younger age groups. Distracted driving is one of the main causes of road injuries. And it's defined as anything that takes your attention away from driving. And they're usually categorized in three main categories, so either visual, manual, or cognitive distraction. On the right side of the screen, you can find some of the most useful, some of the most important distracted driving activities. You can see that, for instance, dialing in your phone or reading and writing texts increases your odds of having accidents by quite a lot. These are European data. And the same report also tells us that Portuguese love to use their phone while driving, and this results in a lot of mortality. Then there's also seatbelt use. Correctly using the seatbelt, so over your shoulder, not twisted, and no slack. It's very important to avoid fatalities and as you can see on also from another report by the same authority, you can see that the use of seatbelt reduces drastically fatalities in road accidents. And regarding media influence, you can see that it has an effect on health behaviors. And we think, or we found some evidence that media also influences your driving behaviors. So with that in mind, we looked into carpool karaoke. As most of you already know, carpool karaoke is a very famous segment from the Late Late Show from James Corden, and where the driver is a famous comedian, and he's usually someone who's a media star, usually someone who sings, and they're driving, and usually under the pretense that they want to use the carpool lane or some other pretense that they need help or some some other pretense. And it's so famous that it also resulted in international versions. So you have versions in Italy, France, Portugal, and many other places. And it has billions of views both on TV and streaming services. So with that in mind, we want to look on the behaviors and the seatbelt misuse in carpool karaoke. This was a proof of concept study, so what I'm presenting you is very preliminary. We just wanted to be sure if we were able to do it. Since the software we are using is very expensive and we have no funding, we wanted to know if this was feasible. So from a non-random sample, of segments, we used coding techniques and we looked to both distracted driving behaviors and seatbelt misuse. Initial coding rules were based on the reports I showed you, and then we adapted into what we were seeing in the coding process. We used MaxPDA, which is also used for qualitative data analysis. And as you can see, we have a video, and for each segment, we have coded all the different activities that are going on regarding distracted driving and seatbelt misuse. In this still frame, you can see that the passenger is not using the seatbelt correctly. You can see that the driver is with one hand off the wheel, is singing, is dancing, and he's not looking at he's not facing the road. So this is not what you should be doing when you're driving. This is not what you should be telling people to do. This was we scanned through all the episodes we chose, and multiple times. This was very time intensive, and we coded all the different different distracting behaviors and also the seatbelt misuses according to these rules. As you can see, we were looking if the person was dancing, if there was one hand off the wheel, two hands off the wheel, if it was singing, talking, looking at the passenger, looking at the radio, looking at the phone, eating, drinking, stuff like that. Very preliminary results show us that we found all of the different distracting behaviors that are in the literature, all of them. You can see they're fist bumping, they're touching the driver while he is driving on the one on the right one. I'm not sure who are the celebrities, I'm sorry. They're eating, he's not looking, he's dancing, and well, you would be expecting him to be dancing and singing, but all the other ones, maybe they shouldn't be occurring, especially seatbelt. It's very easy to use the seatbelt correctly, but we see a lot of times that's not happening, both from the driver, the passengers on the front, and in the back. The full-scale study was found to be feasible. It took around 2 hours for each episode, but we found that it was possible to code, and then we would have statistics to use on a later thing. So we want to bring the discourse that besides media campaigns, this is a media campaign in Spain with famous comedians. besides media campaigns, we should also be aware of how the media are either real or fiction, how it portrays driving and how that is influencing our communities. So, uh, despite being in controlled conditions, the people perceive it as real driving, so we have to take that into account. Thank you very much.
Thank you for your very, very original research. My question is, what are the practical implications of your results in a practical way for road safety and media production in general?
Well, there's very little evidence regarding how media is influencing driving behavior. I think we should look further into that. But this was more of bringing the discourse. You already have questions regarding cigarette use or alcohol use in media, and this is another health behavior that is still not very talked about. So it was more about bringing this discourse, and we still don't have all the results. The study is now ongoing. We saw that it was feasible, so we are now doing the rest. It's very time intensive. We have no funding, so it will take a little bit. But that's the main objective, to bring this discourse and to maybe incentivize other people to research, to further research around it.
Thank you. Thank you for your presentation. So you said it's a feasibility study for new study. So does your team has prepared a protocol for what will be the study you would implement if you had the funding and everything?
Yes, we have the protocol prepared. We were just recently training the other coders because we defined the coding rules, so we now have to train people, and then they will be able to scan for the rest of the episodes. We're doing the whole show. I think it's ended now, so we're doing the whole, I think, 50 or 60 episodes, and we have everything already defined and protocol, and it's already ongoing. Any other questions?
Thank you. I think it's important. In Italy, we've just changed the road safety codes and pushing much more on alcohol and drugs instead of this kind of behaviors, because it becomes very useful to political agendas. So I think it's really important to bring that these things too. My question is that I think it's really useful to be able to kind of analyze social media videos instead of we do a lot of Twitter, but I think it's a bit, a very specific demographic of the population. So how do you think, do you think it can be applied to study other trends too? And how, you've already said it's quite time consuming, but how do you see it developing, and is it can be scaled up to do other type of analysis?
Yeah, we saw some research that used some automation techniques with machine learning with dash cam footage, and they were able to detect if the person was looking at the road, if they were wearing the seatbelt. So I think that's an approach for easier scalability, instead of having people coding things all manually. We don't have that capacity now, but I think that would be one approach. We could look into YouTube. There's a lot of dash cam videos on YouTube. Most of them look outwards, but some of them also look inwards. So you could use that to train a model to then have more data regarding this kind of activities. Because it's very difficult to have data on how people are behaving. It's mostly based on surveys, usually post-accident surveys, and there's very little natural, real-world data. Be careful in Italy because you're not using your seatbelts a lot. From what I've read, just people use seatbelts.
Thank you.
Thank you very much. Thank
you very much. Next is John Henry.
Good afternoon, everyone. My name is Diogo Carreiro, and I'm going to present you my research named titled Key Exposome Variables Influencing Asthma Diagnosis in Children, Insights from a Cohort Study. These are the topics that I'm going to talk about. And now for introduction. Asthma, as we know, is a chronic disease characterized by cough, dyspnea, and wheezing, by inflammation and reversible airway obstruction. It is caused by an interaction between genetic and environmental factors. In this slide, we can see the impact of the asthma worldwide and in Portugal as well. And regarding what the literature tells us, there is evidence that exposure to air pollutants is associated with diagnosis of asthma. Also, about green and blue spaces, there is also evidence that exposure to green and blue spaces is maybe associated with a lower risk of asthma. Also, higher prevalence of asthma in less deprived adolescents. And there is a positive association between asthma diagnosis in children and high temperatures. Now I must clarify two key concepts. One of the concepts is the exposure, which is the totality of environmental exposures from prenatal life onwards. It is a dynamic variable that evolves throughout the individual's life. Here we study the external exposure. And also the built environment, which is the human-made surroundings that provide the setting for human activity, ranging from buildings to parks to neighborhoods and cities, which can include their supporting infrastructure, everything that is around us. The objectives of this study is to analyze the differences between the groups of children diagnosed with asthma and those without, and determine which variables are most critical in the development of asthma. For this, our study population was the Generation 21 cohort. This is a birth cohort from Porto, where that included children that were born in one of the 5 maternities in Porto's metropolitan area. The outcome variable was the self-reported asthma diagnosis at 10 years of age. For this, in order to retrieve our geospatial data, we used multiple sources such as Copernicus Initiative, NASA database, and even the lab study, and some more. And we did some processing in order to get the data in the same formats, using PGs and some Python scripting. After that, we did georeferencing using ArcGIS to their own addresses. We had a total of 41 exposome variables that could be categorized into natural spaces, weather, air pollution, traffic and noise, and built environment, and they were measured at 11 time points. So we got at the end 451 variables. In order to classify all those variables, we needed a model that could work with such a number of variables. So we used the random forest classifier model, and after hyperparameter tuning, we ordered the variables by feature importance. These are the number of participants in our study and the proportion of the people that answered yes, no, and the people with unknown or missing values. And here are the 10 most important variables for asthma diagnosis. And as we can see here, we have some variables related to traffic, such as the street intersection density and the inverse distance to nearest road. Also, some of them during earlier stage of life. Also, some variables related to the built environment, such as building density at 9 years old, land use mix at 2 years old of age, and the building density at 3 years old, and also some variables related to the natural space, such as the distance to the green spaces, land without vegetation, and the NPPI, which is which is related to the percentage of green spaces. Here we can see the variables scattered during the different stages of the child's life. As we can see here, there are no weather or air pollution variables in the most important ones, which is kind of odd, as we know that air pollution is related to asthma diagnosis. But we can see the natural spaces, the impact of the variables are spread throughout every stage of a child's life. Traffic is mostly important in the early stages, and the built environment mostly important in the early stages and also in the later ones. We can conclude about the importance of the green spaces, the traffic and the built environment for diagnosis of asthma. This could guide for future studies about this and urban planning regarding optimizing the streets and building more green spaces. But this study isn't without its own limitations, as some of the geospatial data didn't have really high precision, and our model didn't have a really good rock calc value. The acknowledgements, the funding for this study. Thank you, everyone.
Hello, thank you so much for your presentation. I wonder if you could go back to the percentage, the weight of each of the factors. So I'm not an expert, I don't know this methodology. I would just like to make a question for you, which is the values that appear on the right column. Because of this methodology, are they adjusted to be taken into consideration each of the other ones? With this, what I mean is, does each of these variables take into consideration the impact of other variables?
Yes, every one of them. If you sum all these values out of every 451 variables, the sum will be 1.
Okay, okay, that's what I wanted to know. Thank you.
Hi, thank you. I just have a question. I'm not sure if it's the very same number, but in the introduction, you said that the prevalence of asthma in Portugal was 6.1. Is this from another study? Because we got exactly the same one?
This was, I think that this data was gotten from INE, our national data system.
And you got exactly the same number in your study, 6.1?
It was, yes, it was a coincidence.
Thank you for your presentation. Sorry, what was your special resolution?
The spatial resolution, it depended on the variables. For example, the weather variables weren't very good, and that might be one of the causes that we didn't get one of those variables in the most important ones, because some of the weather variables had a 10 kilometer per 10 kilometer resolution. As our study was most of the children live in Porto metropolitan region, they could add the same values and we could not discriminate between them. But on the other side, some of other variables, for example, the green space ones that we got from competitors, I think it was, and a 2 by 2 meter resolution. It was really heavy computing working with those ones.
Did you have including also some variables around biodiversity? Because it has been shown that for allergies and asthma, it does not kind of agree.
Regarding biodiversity, there were some variables regarding only the type of trees. Only the type of trees, but it was categorized into 2 types. I think it was, I don't know if it's in English, trees with leaves and trees without leaves.
Okay, so I'm just seeing right here that so what are the characteristics like spatial
The characteristics of these missing values. Follow was because this data came from a cohort study, and this variable was measured at the child's 10 years old of age. And most of these missings are follow-up losses, people that left study. That's
Thank you very much.
Thank you.
Once again, everybody will be there for the coffee break, so really work. Last, we have Clara Guttelli.
Thank you, Sophia. Good morning, everyone. I'm really happy to be here and to present you my project, even if I left my project yesterday's karaoke night. So, in France, there are 5 million informal family caregivers tending to cancer patients. Literature tells us that these represent a population at heightened cancer risk because they be gassy, they put all their efforts in tending to their loved ones, and they end up neglecting their own health, and they are more prone to risky behaviors or unhealthy behaviors in order to better cope with stress. We also know that, on the other hand, caregivers have a better perception of their own cancer risk and a greater motivation to change their lifestyle. We also know that in France, 41% of cancer are now attributable to daily behaviors that can be acted upon. Therefore, it seems pertinent to us, as Sandra ended up, to build, together with 3 informal caregivers, a personalized primary prevention intervention on modifiable cancer risks. The study was funded by Institut National du Cancer, et donc our main objective was evaluating the feasibility and the acceptability of this kind of intervention, while secondary objectives included the adherence on the different stages of the process, the experience of informal family caregivers throughout the whole intervention, and we tried to evaluate the short-term impact of our action concerning knowledge, cancer risk perception, intention, and behavior change. So here you have an overview of the full intervention. So after recruiting, we propose a consultation, a medical consultation on prevention, so preventable risk factors. I'm going to explain in detail later. At the end of which, if the caregiver wishes so, we could build together a personalized primary prevention program in order to help him go towards a healthier lifestyle. There was also a follow-up consultation at 4 months that was proposed to them. So here we are concerning the prevention medical consultation. We chose to focus on 6 risk factors that you can see here in the slide because we have relevant evidence linking them to cancer, either as enhancing cancer risk or enhancing protective action towards cancer. We thought it was appropriate also to do a little bit of secondary prevention, explaining and verifying adherence to organized cancer screening. So it is built to be a moment of non-judgmental exchange towards the current ministerial recommendation around these 6 risk factors to assess the caregiver's exposure and, if he wishes so, to accompany him towards a healthier lifestyle. And we also give out ministerial information material to help information sink in. At the end of the consultation, we built a personalized primary prevention program. There's a dedicated leaflet, which is give to him in the consultation if it is in person, or we send it by email if it is an online consultation. And so the caregiver can decide to formalize 2 kinds of objectives. He can decide to consult informative resources like existing websites, or to consult a health relationship and observatory needs. And lastly, to engage in personal actions. Here you have the example of 4 types of factors, but this can be declined for each risk factor. that we discussed during the consultation. There is also a dedicated space in the leaflet in order to accompany you throughout the process to enhance what were the barriers and the levers in actually trying to make this objective a reality. And in the end, there's also a list of useful websites that contain, on the one hand, information, and on the other hand, tips on how to get to a healthier lifestyle. So these are the preliminary results. We included 126 patients, and in the end, we did 48 initial consultations and 35 follow-up consultations. Please note that 6 patients are now being contacted to program a follow-up consultation, so this number could potentially rise up to 41. Concerning our objectives, so our primary objective was evaluating feasibility and acceptability of the intervention. For feasibility, we evaluated the participation score to the entire intervention, which is at least 30%, because in our best case scenario, if the 6 patients that are being conducted to participate, this will go up to 35%. Concerning acceptability, 100% of the respondents declared that the decision of participating in this personalized primary cancer restoration intervention was good for them and do not regret participation. Concerning our secondary objective, adherence to different intervention stages, we had some difficulties in recruiting caregivers since there is no direct way to have access to them. We are forced to pass through patients. So we had quite low percentage of answers to our recruiting questionnaires. However, we managed to have 41% of those contacted in the first consultation, and we see that they tend, once they come in the first consultation, to come back with a very satisfying percentage. You can see 73 and potentially up to 85. Concerning the experience throughout the process, this will be object of a separated publication. But for the moment, there are several individual qualitative semi-structured interviews that have been carried out. And between the main points that emerge are the non-judgmental character of the intervention, the need for reliable information on cancer risk factors, and of course, the months of caregiving condition that sums up and that must be taken into account whenever there is an intention of behavior change. Concerning our short-term impact, we gave knowledge and cancer knowledge and cancer risk perception questionnaires. Unfortunately, due to the low effectiveness, we cannot perform any statistical tests to see if there is a significant difference. However, we see that there is a slight improvement in concerning knowledge. And unfortunately, regarding intention and behavior change, the analysis is still in progress. So, to sum up, it is, to our knowledge, the first monocentric pilot study conducted with partner caregivers on the theme of primary prevention of modifiable cancer risks in caregivers at increased risk of cancer. The intervention is acceptable and feasibility is correct, and sustained adherence emphasizes the importance of such kind of interventions to answer caregivers' unmet needs. However, recruitment is definitely a weak point. Some solutions are already adopted, but we are still thinking on how to maximize the recruiting and also how to better target most vulnerable caregivers that are thus more in need of this kind of intervention. Because we saw that the majority of our participants, not unfortunately, but they had a high socio-economical profile. So we constructed with caregivers name for flyer in order to give to consultation and raise knowledge of this possibility. And together with the rest of the staff of the Centre Lambera, we are trying to push people to propose this consultation, to be aware that this instrument exists right now. And we are also doing close collaboration with territorial external prevention. More concretely, there is a transferability study ongoing at Institute Gustave C with a twin project aiming of targeting the most vulnerable caregivers. a project that aims to systematize this intervention at Centre Lamberar, and there is a prevention building that has been started to be built. So our aim in the future will be not only to open up this kind of intervention to all kind of caregiver, not only cancerology caregivers and not only cancerology caregivers of patients that are being followed up at the hospital, but potentially also to people like me and you that would like to assess their cancer risk or in general to better take care of their health. And there will be also the PhD thesis of Pauline Dicon, which is the other medical doctor in charge of medical consultation with me. So thank you very much for your kind attention. And,
Thank you very much. So we heard all of the presentation. I would like to thank all of the presenters very much. The quality of the presentation was really nice. Thank you for sticking to the time. So thank you very much. And I think that we will have the coffee break. Yes. Do you want to give indications? Yes, it's coming. I believe. But thank you very much for being so brave and being here after the karaoke night. Thank you very much.
Okay, so now we're going to go to the cafeteria, and so you and I will lead you to like where to get to the cafeteria and just to recharge a little bit of energy, and then we're coming back to the United States. So just enjoy the coffee. Okay, come.